We want to thank our co-sponsors, Northwest Bronx Indivisible, Our Bronx, Lower Hudson Valley DSA, Westpac Foundation, Bronx United Progressives, Campaign for New York Health, Physicians for a National Health Program, New York Metro Chapter. So we're going to start with the healthcare system that we have now.
Grab the wrinkly dog, 11 letters, and it's a rhyme.
Grab the wrinkly dog, and it's a rhyme?
Hey, my apartment's on fire. It's right around the corner. Come on.
Whoa. First things first. Are you insured?
Yes, sorry. Here you go. If we could just hurry, though, that'd be great, because my apartment's literally on fire.
We got a slight issue here.
What issue?
It says here you're behind on your premium payments.
Really? I don't think so.
I do. It's right here on your file. $660.
Oh, my bad. Can we just take care of that later?
No can do. See, your specific provider, Bright Shield Protector Fidelity Horizon, says you need up-to-date premium payments for your provider to be reimbursed. Can you not talk over me?
I was talking with you to support you.
So the thing is, I haven't reached my deductible anyway, so it would all be out of pocket.
Right, but to get credit towards your deductible, you need to have up-to-date premium payments.
Okay. Sorry. Here you go. Here's my credit card. If we could just hurry, though, that'd be great, because my apartment is literally on fire.
So sorry, but we don't take American Express. Talking over me.
Oh, sorry. Here you go.
Actually, hold up. This isn't your home precinct.
It should be. I live right around the corner.
New address?
Yeah, we moved a couple months ago.
Well, that's an issue because your primary care precinct is still tied to your former address. This precinct is out of network for you, so I'm going to need a referral.
A referral? There's a fire in my apartment. Right now.
Oh, dear.
What?
Did you recently change jobs?
Yes, so what?
There's a gap in your insurance.
Your old coverage was tied to your old job, so when you shifted jobs...
My home is literally burning down!
Hey, could be worse.
How?
Was it on fire when you moved in?
No, of course not.
Seen it before, and then it's a pre-existing condition and it's
Not covered. See how it feels?
I kind of like it.
Oh,
What?
the crossword. Carpe Sharpe.
Ooh, nice pull.
This is absurd!
It would be absurd if we ran fire departments like this.
So why do we run healthcare this way?
Hey, I live right next door to you. Your apartment fire spread to my apartment.
Oh no, I'm so sorry.
Here, take a bucket. Can you help us?
Are you insured?
Okay, taking from there, we'd like to know about your experiences. I'd like a show of hands. Who loves their health insurance company? Raise your hand. Nobody? You love your health? No, you're allowed. We accept all points of view here. Whose premium went up in 2026? Okay. Who is worried or very worried about affording health care or long-term care in the future? Who has had a claim denied by an insurance company? Who is thrilled with the way our healthcare system works now? Okay, we've got a pretty good backup for our video. Okay. Our next thing will be Helen Krim, activist extraordinaire of Northwest Bronx Indivisible and the Campaign for New York Health. She has a brief PowerPoint, which you can see in its entirety if you go to some of her other events. We kept it brief because we want you to be able to ask a lot of questions of our speakers and for them to talk. So.
On that note, people took cards, I hope, or were given cards when you came in. If you want to write a question, we're going to have pass in the cards. I think that's going to be a little more time saving. So just write your question, raise your hand. I'm going to be looking, and you can, while people are speaking, if you have a question written down, so I see some already, I'll come get them, and we'll be reading the questions to our speakers and panelists after their presentation.
And there are extra blank cards and extra pens at the place you registered, so you can just slip up quietly. Hello, I'm Helen Krim. Been working on healthcare for quite a few years.
but I'm very optimistic because things are getting so terrible that I believe the tipping point is coming. And anyway, can we get started? This is our current system. As you can see, the US spends more on healthcare than any other industrialized wealthy country, more than twice as much. Next slide. Americans live the shortest lives and have the most avoidable deaths. And there we are at the bottom, the US, and all the other industrialized countries are above us. The US is the only country that does not provide universal health insurance. Next slide.
We're the only countries.
Not surprisingly, 740,000 New Yorkers have medical debt. Healthcare is and will continue to be too expensive for the majority of New Yorkers. Too much of what we pay gets funneled towards insurance companies instead of going to our healthcare. And every year, the insurance companies demand that we pay more for less. So the co-pays get greater, etc. Next slide. Now we're facing federal attacks against New York and against the whole country. The $13.5 billion in healthcare cuts. We are expecting 1.5 million people to lose health insurance in New York State. That's what I mean by the tipping point. Can we move to the next? The result will be healthcare center and hospital closures, and we're already experiencing that. Longer ER wait times, and the costs will continue to go up unless we do something dramatic. Next. Our current system is designed to maximize the profits of the healthcare system and the insurance companies and the pharmaceutical companies and the hospitals. That means that we cannot afford to let this trend continue. It's driving too many people into debt. Can we have the next? Our solution is the New York Health Act. This is a bill that is going to resolve this problem. Next, please. And now you're going to hear from real experts.
So the setup is we're going to have each of our really honored speakers, the top-notch people that we could have gotten. We're going to have each of them speak, and then we're going to set them up as a panel to answer your questions, to do a Q&A. So our first speaker is Richard Gottfried, author of the New York Health Act. He's going to talk about what the bill does and anything else he feels like throwing in.
Okay. Well, we can go to the first slide. So I always like to start with a literary reference. Let's see if I can do this by memory. Here is Edward Bayer coming downstairs now. Bump, bump, bump on the back of his head behind Christopher Robin. It is, as far as he knows, the only way of coming downstairs. But sometimes he feels that there must be another way, if only he could stop bumping for a moment and think of it. By the way, I'm also reminded of what Winston Churchill used to say, which is, you can always count on the Americans to do the right thing after they've tried everything else. So the answer is the better way is the New York Health Act. It would cover every resident of New York State with complete health benefits, better than the coverage that any of us in this room or any other of the 20 million New Yorkers now has, including long-term home care and nursing home care. And it provides real choice, no restricted provider network, no restricted drug formulary, no prior authorization for health care, and no premiums, deductibles, co-pays, or out-of-network charges. No out-of-network charges because there will be no such thing as out-of-network. How do we pay for it? It's paid for fairly through a progressively graduated tax based on ability to pay. Part of the tax would apply to earned income, essentially payroll income, and your employer would be required to pay at least 80% of your New York Health Act payroll tax. They could pay more, for example, through collective bargaining, but would be required to pay at least 80%. And other taxable income, subject to New York State income tax, such as dividends and capital gains, would also be taxed by the New York Health Act tax. The first $25,000 of income would be exempt from the tax. And part of the logic there is that if you're earning that little income, you're probably covered by Medicaid, and it would be kind of rude to make you now start having to pay for that for your health coverage. And if you're on Medicare, which, looking around, an awful lot of this room, like me, are people on Medicare. If you're on Medicare, the first $50,000 of your income would be exempt, basically acknowledging the fact that as a Medicare enrollee, you are bringing an enormous amount of federal money into New York's healthcare economy. Now, there have been any number of professional studies done on the New York Health Act, and I think Peter Arno will be telling us a little about that. And they all show that almost all New Yorkers will pay less in New York Health Act taxes than we now pay for health care and coverage. Next. Now, we're facing massive federal health care cuts, and just as the New York Health Act will fill the gaps in our current health coverage system, it will fill the new gaps created by the federal cuts in health care. And it will do it by using a portion of the savings that the New York Health Act will produce. So it will cover those new gaps without costing New Yorkers more, without requiring the cutting of other things that the state now pays for, and because the money that the New York Health Act raises will be used to pay for health care and not insurance corporation waste. Next. Now, a lot of people ask, will it be a good plan? Americans tend to think if it's something the government does, it's got to be, kind of crummy. I could ask for a show of hands, but I won't. And the thing about the New York Health Act is that unlike a lot of public programs, it will cover the governor, it will cover every member of the legislature, their families, their friends, their campaign contributors, and they will have a vested interest in making sure that it treats them and their healthcare providers as well as can possibly be done. 20 million of the rest of us get to be part of the same health plan. And a lot of people say, well, if it's going to be so good, why does it have to be universal? Why not make it what they call a public option? Well, the answer is, if it's just one more piece in our fragmented healthcare system, you don't get the real savings that come from having a universal plan and getting rid of the insurance companies. And also, if some people are in the plan and some are not, that undermines the phenomenon of all in the same boat, which helps guarantee the quality of the program. Next. People, of course, ask about how this affects Medicare. The bill guarantees that all rights and benefits you now have under Medicare will be continued. And of course, Medicare is a federal program. New York could not tamper with your rights and benefits anyway, but the bill says, even if it's a little redundant, your rights and benefits under Medicare will be guaranteed. And in fact, the New York Health Act will fill the gaps under Medicare, so there will be no need for anything like Medigap coverage, or what I like to call Medicare disadvantage. And there will be, because there will be no extra costs, deductibles, copays, etc. The New York Health Act will pay all those on top of what Medicare now pays. Next. Now, people often ask, well, don't we need some kind of federal permission to do this? I hear about, Medicaid waivers and the like. Can New York do this legally on our own? Well, the answer is absolutely, yes, we can. We do not need any kind of federal permission. Both Medicare and Medicaid allow states to fill the gaps in those programs. And New York has always done that. New York had a senior citizen drug program years before Medicare Part D. We still have that program because guess what? It fills the gaps in Medicare Part D. New York Medicaid, from the day it opened its doors in 1970, covered segments of the population, like adults with families without children, that Medicaid initially did not cover. Since 1978, with the Hyde Amendment, Medicaid dollars cannot be used, federal dollars cannot be used to pay for an abortion. Well, New York, through its New York's Medicaid program with state dollars, does cover abortion. Obviously, the federal government did not give us permission to do that. We just do it. I often mention that, I'm a retired state employee. When I go to the doctor, Medicare pays most of the bill, but my state employee retiree health benefits, and I always try to remember to thank all of you for paying for my retiree health benefits. My retiree health benefits pay a fair chunk on top of what Medicare pays. Now, New York did not need federal approval to do that. We just do it. And the New York Health Act could run similarly. Next. So there are a couple of ways the New York Health Act could work. One is if the federal government says, you people in New York, you're nuts, we're not going to have anything to do with this, then the New York Health Act will simply wrap around Medicare and Medicaid the way my retiree health benefits wrap around my Medicare. When I go to the doctor, if I show them my Medicare card, I show them my New York State retiree health benefit card, and the doctor's computer makes sure that they get payment from both of them. I don't think any human being has to actually touch that process. It's all done by computers, and that's how the New York Health Act would work. Except, of course, when I go to the doctor now, I have to pay a copay. I won't have to do that anymore. Now, it would be even better if the New York Health Act, if the federal government says, New York, you've got a good idea. We'll give you the money we now spend in New York on Medicare and Medicaid, put that into the New York Health Trust Fund, guarantee that nobody will lose any federal benefit, which the bill does, and you can run it all as one program. That would be simpler. It would save the federal government a few dollars. It would save New York a few dollars. But if the federal government says we want to have nothing to do with the New York Health Act, okay, it can, again, run reasonably well, perfectly well, as a wraparound program. Next slide. If you want to reach me, jot down my email address. If you've got more questions, the Physicians for National Health Program and the Campaign for New York Health, those are their web addresses. You can get a lot more information. And if you really want to dig into the weeds and read the bill for yourself, like if, you really have nothing to do some afternoon, there is a website, Public Ledge Info, where you can put in the bill number and the year and hit, search, and the bill will pop up. You can even print yourself out a copy of it. So that's my message for today, and thank you for coming. And later I'll be part of the Q&A.
Thanks, Dick. I've read the bill 3 times, and I just want to say, as it's changed, that if you have any questions, all you do is write to Dick and he answers them all. I was stuck. Okay, Betty Kolod, a doctor and chair of the board of PNHP Metro, Physicians for a National Health Program. She's going to give us stories from a doctor's perspective, and having heard her speak before, I can tell you that she'll bring you to tears in a good way.
Hopefully it won't bring us down too much, but this is reality, unfortunately, and you're all living it, so you probably don't need to hear it from me, but I just wanted to share some of my experiences, and I get called upon to do this pretty frequently, and for better or for worse, really for worse, I have new stories every single week, every single day. So these are hot off the presses. And I just want to start by saying I'm so thrilled to be invited by my mentor, Dr. Debbie Swiderski, to be part of this event. And a little bit about my background. So I'm an internist, I'm a public health and preventive medicine physician, and I'm board certified in addiction medicine. I work as a primary care doctor in the Bronx and Manhattan. So as you can tell, I've done a lot of training. I'm very busy, but working to pass the New York Health Act is the #1 most important thing that I can do for my patient and for the community that I live and work in. So I was a little bit undisciplined with picking stories. Usually I try to limit myself to 1 or 2, but this week was really a doozy. And what really struck me this week was the way that the profit-obsessed healthcare system is harming people across the lifespan and across all income brackets. So for me, as an internal medicine physician, the lifespan starts at about 21. So I'm going to start with a story about some Gen Z people. So on Friday, I participated in a National Public Health Week event. It was an educational event for college students and master's students. We were talking about global health and trafficking and violence and sex work and all of these issues beyond healthcare in the United States and here in New York. And what the students wanted to talk about and what they were most affected by in my remarks was the New York Health Act and just how terrified they are of getting sick. This is what people in their early and mid-20s are thinking about right now. They came up to me and they said, I cannot afford to get sick. So moving on the lifespan, thinking about my patient Raul, he's my success story. So when I first met him, he had just had 11 drug overdoses in the past couple months. His mom had lost count of how many times she had Narcaned him. He was 6'2" and weighed about 120 pounds. But he is now strong, healthy, and he is working, and he's doing fantastic. He hasn't used drugs in over 2 years. He's doing very well on a monthly injection that we're giving him for his addiction, And he recently was able to join a union. He was feeling really positive about his outlook in life. And as soon as he switched from Medicaid to his union insurance, that's when the bills started coming in. So recently he found out that his 32BJ insurance is no longer in network with our hospital. So we were scrambling to find a doctor who would take on his care. Then the decision was reversed, and they said, oh, no, wait, actually, we'll keep taking his insurance, but only till December. So, okay, things have calmed down for a few months, and he and I were talking about this, and he said, but I don't know what's going on. Why am I getting a $60 bill for every doctor's visit? I come in here every single month for my injection. Are these being charged as specialty visits? So I went to the front desk, and I had to go to the administrator, and I talked to all these people. I sent all these emails, spent a bunch of my lunch breaks trying to figure out what was going on. It turns out that's the facility fee that he gets for his primary care. So again, this is just one part of our profit-driven healthcare system, but why is this necessary? This guy is doing great. Let's keep him on track. The next story that I wanted to share relates also to medical education. So I was working with medical students in the hospital this week. And a medical student came to me, and he was really puzzled by a particular case that he was working on. He was working with a young man. The patient was actually the same age as him. His wife was pregnant. She actually went into labor while this guy was admitted to the hospital. And this patient had very severe diabetes, and they could not get his blood sugar under control. And they were like, what is going on? This is a young guy. He's underweight. Why is he dying of diabetes? And so we spent the entirety of this admission not talking about the biomedical sciences of how you can optimize somebody's health care when they have diabetes, not talking about how you can manage diabetic ketoacidosis, which really should be managed in an intensive care unit. So that's another aspect of this. Why was this guy on a hospital floor? But we were talking about what was going on with his insurance. Why weren't any of his medications covered? This guy had been to 3 different primary care doctors in the last year. His medication list was getting longer and longer and longer. He was up to 8 medications that he was being prescribed. We found out he wasn't taking any of them. Turns out he's on emergency Medicaid, not regular Medicaid. And emergency Medicaid, we taught the medical students, doesn't cover medications at all. Why is this what we're teaching our medical students? This is not what medical students need to be learning. But this is the money that we're wasting on our fragmented system, a patchwork of Band-Aids, just to try to get people the minimum amount of coverage to keep them out of the hospital. 2 other people I wanted to share about. One is my patient Judy, who I love. We've been working together for 9 years. She's a retired office worker. She's got this classic New York accent, really raspy voice from decades of smoking, great attitude, and she, as you can imagine. So she received the awful news in the past couple months that she has pancreatic cancer. Wow. So these are the last few months of her life that we're looking at right now. And she was on a Medicare Advantage plan. So her kids just spent the last 2 or 3 months scrambling to get her on traditional Medicare, get her a Medigap plan to make sure that her chemotherapy would be covered, that if she needed surgery, that would be covered, that the oncologist she wanted to see would be covered, because all of these would be at risk on a Medicare Advantage plan. Again, why is her family focused on this right now? In the last months of her life, she is dying. So Judy came in to see me earlier this week, and she said, I did something really stupid. She was watching TV late at night, and she saw an ad for Medicare Advantage. She said, these perks look pretty good. And she switched back to Medicare Advantage. So she found out she was planned for surgery, and that surgery had to be canceled. So this isn't just taking away her last few moments with her family. This is actually going to hasten her death. And the final story I want to share is very personal for me because it's about my mother. This was very difficult for me earlier this week. My mother came to me. My mother is an incredible person. She's 75. She's a psychologist. She had just come back from biking in France. She's in incredible shape, and she got a cold while she was traveling, and she said, oh, my cough was really killing me. I need to be at work, and I couldn't sleep. So I called my primary care doctor. This is the family medicine practice that we've been going to since before I was born. And she said, can you just prescribe me some stronger cough medicine? And they said, no, we cannot prescribe you any medication without a visit. And she was like, I have a visit, I have my annual in 2 days, you can't help me out? And they said, no. And she said, well, what about virtual visits? And they said, no, we don't offer that. So she came in for her annual 2 days later, exhausted, and she, leveled with her primary care doctor she's been seeing for decades. She said, what's going on? Why can't you be a little more flexible? And his eyes welled up with tears. And he said, if I could quit today, I would. He said, I can't do this anymore. With all the restrictions, with all the payers, everything I have to manage, I just can't do it anymore. And so my mom called me and she said, my question isn't, can you recommend a different doctor? My question is primary care available anymore? And it was really painful for me because I didn't know what to say to her. I mean, she's right. I don't think the primary care is available anymore. It's really hard to get a primary care doctor because of the way healthcare is financed in this country. She was like, should I go to concierge medicine? Which killed me. I cannot recommend just further fragmenting our healthcare system that way. So, I had to get into explaining our segregated healthcare system to her, that people with Medicaid, they go to these clinics. People who have Medicare like you, they go to these other clinics. And it made me sick. So, I don't think we can make it another year like this. I really don't. And I'm scared. Across the lifespan, across all income brackets, we need our government to step in and protect us from the biggest threat to our health, which is profit-driven healthcare. That's the real threat. As Eileen said, this is the role of our government. We need you to step in. We need the New York Health Act. So I want to invite you all to join Physicians for a National Health Program, New York Metro chapter. It's not just for physicians. So we have an event coming up on Tuesday. It's a statewide mass organizing call. We're coming off of a very successful lobby day that we had a couple weeks ago. We're going to send out the information, but if you go to our website, pnhpnymetro.org, you'll see right at the top under this event, there's information about our mass organizing call on Tuesday at 7:30. It's on Zoom, and you'll learn more about how you can plug into this work. We need you. Thank you.
Thanks. And now we have a force of nature, Gustavo Rivera. Gustavo is going to, well, we all know he's the chair of the New York Senate Committee on Health. Right. He's going to do what can we do to get it passed, and my original note was, what can we do to get it passed on steroids? That's Gustavo.
Always have to salute Gottfried and Dr. Kolod. Good afternoon. So again, Gustavo Rivera, State Senator, 33rd District in the Bronx, just to your south, and Chair of the Health Committee in the Senate. Let's get right to it, because I definitely want to get to the Q&A. We have to make it a political priority. That's the most basic answer that we can give about how do we get it passed. There's a lot of different corollaries to it, and I'll go into a little bit, certainly in the Q&A. But the most important piece is that we have to make it a political priority for my colleagues. The way that we've been able to achieve a lot in the Democratic Conference and the majority, first of all, think about what needs to happen for this to actually become a reality in the state of New York, just on the legislative side of things. We have to pass it in the Senate, we have to pass it in the Assembly, we have to get the governor to sign, right? So those are three not very easy steps. And it's actually funny, well, certainly not funny, but I remember when Dick was in the Assembly and he had passed the bill 4 years in a row in the Assembly. And we should definitely give it up for him because he was able to do that in the Assembly. And then we got to the majority, and I remember telling him, Dick, you're not gonna pass it this year. And he's like, of course you're gonna pass it this year. We passed it 4 years in a row. And the thing is, he had kind of, because he had been related to a majority Republican conference in the Senate, and now we had a new Democratic majority, it was, I kind of knew that it was coming. I guess it was one of the only things that you did not necessarily know, because you know a lot. But this was one of the things that surprised you. It didn't surprise me because I kind of thought that it was going to happen. And what happened? When we became a majority in the Senate, all of a sudden, a lot of things that some of Dick's colleagues who have expressed support for all sorts of things over the years, but they did it when the Republicans were in the majority, so they could say like, it's never gonna pass. Of course I'm a champion for X or Y or whatever, but it wasn't actually gonna be a thing because the Senate Republicans were gonna kill it. But now that the Senate Democratic Conference could do it, then all of a sudden, all sorts of things started getting like, whoa, this might actually become a reality. Well, we gotta slow things down. And unfortunately, the Health Act was a piece of that. We were, as I was picking up sponsors in the Senate, kind of dealing with all the intricacies of the Senate Democratic Conference and trying to get a majority of folks there to support it, a lot of Dick's colleagues, and many of them have moved on, retired, been defeated, so there's a lot of time between the time, it was like a decade ago, I guess. Some of them went to jail, yes. That is my line. I just steal my line. but okay. So the assembly. All of a sudden, you had a lot of people who were his colleagues who were making calculations that they weren't making before, and all of a sudden, it did not become something that they really wanted to do, and so we kind of had to start from scratch. And so the time that I was there, I actually just was made aware by my staff that this year will mark the 10th year that I've been carrying this bill. And I haven't fasted, but I'm working on it. But in all seriousness, but to get back to the Democratic Conference, the majority, one of the things that we've been able to achieve, if you think about how when we got to the majority, there were a whole host of things that have been held up for a very long time. And we were able to get them done, whether it was the Women's Equality Act, whether it was marriage equality, marriage equality we didn't get in the majority, but we did get to protect trans people during the majority. We got a whole host of things for housing, for taxation, the CLCPA we managed to get to the majority, et cetera, et cetera, et cetera. So a whole host of things that we've been, and then sometimes some big housing packages, the congestion pricing, and all these things kind of, a lot of the way that it has worked in the legislature is that the Senate fights it out amongst ourselves, and sometimes we have bloody battles internally, but we come up with a consensus, then we try to get the Assembly on board, and ultimately we get the governor there. So this is kind of has to be a little bit like that. And so there is certainly a lot of work that I'm doing internally to convince my colleagues, but I need the outside as well to put pressure on my colleagues, because the thing is the leader knows that I'm going to run up against a wall 1 billion times for this bill. She knows that I will flip every table available, and that's just because that's just, and she knows that that this is something I sincerely believe in. But if I'm the only one asking her for it, if I'm the only one bringing it up, if I'm the only one that says anything in private or in public or in conference or closed conference or something, well, she's going to say, I would love for this to happen too. But we can't get other colleagues we got to get more colleagues on board. So I have been slowly working. Now there's been a lot of shifting in the Senate in the last couple of years, and there's going to be an enormous shift coming this next year, because we're going to have our deputy leader is decided to retire. The chair of the Housing Committee, Brian Kavanaugh, is deciding to retire. A couple of our senior members are kind of thinking about whether it's their last 2 or 4 years. So there's going to be a lot of shifting that's going to happen in the next couple of years. But the issue has to be that it has to become a political necessity. It has to become an imperative. It has to become something that voters not only ask about, but voters demand that you actually push for. Right? And so like that voter right there, obviously, I think. So I guess that is as a broad thing. getting my colleagues to care about it so that it becomes a political imperative internally in the conference is an absolute necessity. And I think that there's a couple of things that are accruing to our benefit. Dick mentioned it right at the beginning. The reality is that, actually, I did a press conference a couple of weeks ago about the New York Health Act. And the first thing I said was, I want all of you to close your eyes for a second and imagine a world without Trump. I want all of you to do the same. Isn't it wonderful? We actually have agencies, federal agencies that actually care about the work that they're supposed to do. We're not at war with a foreign country where we don't have like thugs roaming our streets, picking up people randomly and murdering American citizens. But in that world without Trump, we still have a profit-driven, but we still have a profit-driven health system. So what I was trying to do at that moment was tell people stuff was bad. Like, we can look now and see that there's an enormous crisis, but things were bad before. But what this means, the attacks that are happening right now, and the fact that this orange madman could not be any clearer when he says Medicare, Medicaid, childcare, we can't waste money on those things. We need, military force or whatever. Like, he's being explicit about the fact that they're not going to say, we already knew that this was the case, that they were not putting those money in there, but now he's being explicit. So this is going to it's doubling, tripling down on the crisis. Because one of the things that everybody needs to be on the same page about, and I think certainly everybody in this room is, but many of our friends, many of our family members, many of our colleagues, many of our folks out there do not really recognize that the system that we're talking about is one ecosystem. And when you have a whole host of people, say, 450,000 of them that are going to lose coverage in July of this year because of changes that happened because of HR 1, or 200,000 more in January because of changes in workforce requirements for Medicaid, or like between now and the end of 2027, somewhere in the neighborhood of 1.7 million New Yorkers are at risk for different reasons of losing coverage. Those people are not disappearing. They're not going into the ether. They are still going to, be humans, get sick, require care, and then put demands on the system that serves folks who think that they're above it because they have a nice coverage. They have a nice shiny insurance card in their pocket. So this crisis should not be wasted. We should not waste this crisis. So pointing out how it's going to actually impact the system as a whole is important to be able to say to folks, this is an ecosystem, it's going to impact all of us. We need to actually really solve it. We need to go in a different direction because continuing down this road is not going to solve it. And then the other thing that we talked about, I think I've talked about in this room before, because it is likely that some people in this room, now, are there some folks here who are New York City residents as opposed to just Westchester residents? Okay, so a couple of New York City residents, and if you're New York City residents, and some of you are my constituents, if I'm not mistaken, and if you're my constituents and you're in Riverdale, it is likely, and you're a retiree, you are likely one of the folks who was at least in part involved in the organizing against the Medicare Advantage switch that occurred for healthcare workers, for retired workers. And for folks who might not know what happened there, the city of New York, there was a decision that was made by the Municipal Labor Council a few years ago because they looked at their finances of their health fund and they're like, yeah, we're not sure if we can keep this going, if we got to do something to save some money. And what they decided was that they were going to switch up the way that healthcare was provided to their retirees to a Medicare Advantage plan. And the retirees were like, I'm sorry, come again? What was it? And then they took all that confusion, they turned it into anger, they turned it into energy, and they organized, and they were able to resist the shift. Not so much so that there was continued legal actions have been taken, and the courts have consistently upheld the fact that this should not happen. And then the two biggest folks who were pushing it, UFT and DC37, one of them said, you know what, I changed my mind. UFT kind of pulled out. And so and the reason why I point that out is because at that moment, a whole host of folks from within those public sector unions started reaching out and asking questions about the New York Health Act.
Right on.
There was actually a meeting that I had maybe a year and a half ago with a mid-size, if you know what, so for folks who might not know, so DC37 stands for District Council 37. And it is a collection of unions, right? And so they all belong to AFSCME, which is the American Federation of State, County, and Municipal Employees, right? So it's a large umbrella, smaller umbrella DC37, which is still the largest such district council in the country, and then a whole bunch of locals that represent different people who work in the city of New York. So one of the mid-sized locals, because there's locals that are a couple of dozen people, a couple thousand, maybe 100,000, but one of the mid-sized locals reached out and said, we want to talk to you about the New York Health Act. Never happened before. It was proactive. We had a meeting, it was about 15 people, all their leadership and everybody, and I'm like, oh, wait, okay, this is kind of like a thing, and I'm like, how can I help you? And they said, and I took them at their word, they said in good faith, we don't want to hurt our retirees, but we thought that the only option that we had to be able to keep the fund alive and viable was to do this, to switch up these services. So if the New York Health Act was in effect, would we have had to do this? I'm like, why do you ask? And we proceeded to actually talk about the bill in ways that they had never spoken about it. They repeated the oft-repeated lies that they have been told by some of their leadership, unfortunately in bad faith. They have been lied to about what the bill does. And in some instances, we were like, the Zoom is a great thing. So we even put it up on the board and be like, wait, you know what? Let's all read it together. And we put it up on the screen. So like, let's read that section. So that, because there were a few instances in which Dick and I talked with them, they expressed some concerns, and Dick said, okay, third concern is tricky, but first and second one, we can solve that with language. How about this language? And as soon as he did that, they were like, oh, look, a squirrel. And this is him. He was left there with like, no, but we solved it. And they just kind of walked away. So but then we started having that conversation. So what shows me is that there are cracks that this whole conversation, that this reality, that the crisis was already, the thing was already bad enough. Then the decisions are being made that actually impact people who have negotiated certain benefits for themselves in their retirement. They fought it. Then people are asking themselves, well, how are we going to keep the thing alive? And then saying, like, is there another way to do this? Is there a better way to do this? And the answer is, of course, yes. So there's a break there. There's a break in UFT as well, because we've been having conversations with their leadership that has moved a little bit, as well as NYCD. There's new political leadership within CSCA, which is a union upstate that has also been resistant to it. So we take that. We take the fact that there's so many unions who are supportive, like the nurses, like 1199, CWA, RWDSU, all these folks. So we take all of those things together. I think that we might be close to a turn. And that turn is what we're going to talk about. Thank you.
We're going to set up our panel on this table to answer questions.
The New York Health Act has majority support in the legislature for years. Who and what is holding it up, and what can we do to get it passed and get it into law? And then a related question is what you touched on at the end about the union support. So maybe the question for both of you and someone in Gottfried. Can everybody hear? What can we do?
Not hearing the question.
What can we do to get this passed?
I'll reiterate. It's like the union issue has been ironically and tragically the biggest obstacle. It has not gained more traction because you can actually see. I say it all the time. There's a difference between being a supporter of the bill and being a champion of the bill. Being a supporter of the bill, it's easy enough to send me a document that you sign, and all of a sudden I put your name on the bill. If you're not talking about it in conference, if you're not speaking to the leader about it, if you're not talking about it with your constituents, if you're not working with the Campaign for New York Health to organize town halls in your district, if you're not trying to sign on to a letter that says we need to bring it up for a vote, et cetera, et cetera, et cetera. You're not doing that. You're not being a champion. The fact is that there's a good chunk of my colleagues in the city of New York who, because of the resistance of DC37 in particular, have been reluctant to be more than just supporters of the bill. So that's, And now the faces of my conference are changing a little bit, and some of the politics are changing as well. So there might be some new ways that we can bring pressure, but I think that is a key point. And to reiterate what I said earlier, getting more of my colleagues to be loud about this bill is the way that we actually get it considered in a higher level. And the assembly, I'm going to leave it to this gentleman because he was there for a few years and he saw so many speakers. He can give you his analysis because I still don't understand that godforsaken place. You know, do you? And the bottom line is that that is a separate beast. My colleague Amy Paulin, who's the current chair of the Health Committee in the Assembly, has to, do the bulk of the work over there. That's a conversation you'll have to have with her. I'm worried certainly about the Senate. If I can get over a hump in the Senate, we're like a third of the way there.
I think what Gustavo described as the situation in the Senate is pretty much the same thing in the State Assembly. The bill passed in 2015, 16, 17, and 18 when we had a strong Democratic majority in the Assembly, but we had a Republican majority in the Senate, and so a lot of groups said, we don't really have to worry about this crazy idea because it's not going anywhere. All of a sudden, Gustavo and his Democratic colleagues captured a strong majority in the state Senate, and so all of a sudden, the teachers union, DC-37, a couple of other public employee unions woke up and said, whoops, this could pass in both houses, we're against it. And, a Democratic majority legislative body in the state of New York is going to have a hard time passing a major bill that is opposed by those public employee unions. And that's been the situation, even though you've got a majority of the members of the New York State Assembly and a very solid majority of the Democrats in the State Assembly who are signed on as co-sponsors on the bill. But the leadership does not let the bill come to the floor in either house because of the opposition of those couple of very powerful unions, even though an awful lot of the labor movement strongly supports it.
And I want to briefly, there we go. I want to briefly add about DC-37. So, as the Senator mentioned, this is a collection of local chapters. And the rank and file members of DC-37, many of them do support the New York Health Act. And there's a lot of support in particular among the DC-37 members who work at the New York City Health Department, who work at the medical examiner's office, so that the public health professionals and the physicians and the health workers in DC-37, many of them who understand how the New York Health Act works, support the New York Health Act. And in the next month, we expect to see a vote among these members. And so we may see DC-37 local chapter 3005 maybe endorsing the New York Health Act.
Okay, next set of questions.
One more question. Can you explain to the audience why these major public sector unions are opposed to the New York Health Act, whether it provide better benefits than they can provide, and it would also allow them to bargain for other things like wages, retirement benefits, working conditions, etc.?
There's some good faith arguments and some bad faith ones. And the good faith ones is what I call the bird in the hand problem. These unions are just like the rest of us, existing in an environment that has been fed by the notion that the best way to get healthcare is to get a good insurance product. That's not their doing, right? We are all convinced of this. This is something that's kind of existing. It only takes very few people are forced to think about the fact that there is other ways to do it, right? Remember, we're America, we're better than anybody else, I'm gonna be better than anywhere else, et cetera, et cetera. So it's all kind of built into that. So there is a good faith argument, quote unquote, that can be made by them saying, we have this, which is in comparison to other insurance products, still an insurance product, but in comparison to other insurance products, better than what you can get almost anywhere else. And we have, not only that, but we've given up a lot to have this, which we have in hand. So you're telling us there's something over there, but I don't know, because I got this now. So there's that's part of it. But some of it is, I would say it's kind of bad faith, and probably has to do with the fact that there's a different version of a conversation I had. The guy that led Northwell for a long time. Remember, what was his name? The Irish guy?
Michael Dowling.
Dowling. I remember the first time I met Michael Dowling, who's now retired. He ran the largest healthcare system in the state of New York, Northwell. The first time I met him, I went out to Long Island with one of my senior staffers, and we just sat in one of his offices. We had coffee, and we had like a 2-hour conversation. It was a 30-minute get to know you and an hour and a half debate on the New York Health Act. And it was fascinating, because this is not only somebody who's like, Irish, as in from Ireland, so therefore he comes from a country that has a version of single payer, but somebody who runs a fairly successful and large health system. So it all came down, like we had long conversations about all sorts of things, and it basically came down at the end of it to, I recognize that the system is completely messed up. I recognize it, but I've figured out how to work it. I figured out how to make the best that I can with it. And again, if you take him at his word, and with all interactions I had with him and his actions, I saw the same thing. And I don't think he's a bad person. I think he certainly knew that his actions had an impact on a lot of people that he took care of as far as the healthcare system was concerned. But he was like, but I kind of know this system. So I know it's messed up, but I kind of figured it out. And what you're asking me to do, the second piece, and you talked about this earlier, it's like, and what you're asking me to do is to hand over the system, to government? I don't trust them. I trust the people that I employ who have figured out how to work this completely messed up system more than the folks in Albany who might just mess the whole thing up themselves, and then I have no input over that. So I figure that there are some union bosses who have a similar view. They have figured out how best to make it work with their members, and then they don't. They're like, you're giving me something that's like pajarito preñado, as we say in Spanish, which means like little pregnant birds, or so it's weird. It's a phrase that we use to refer to something that's kind of like imaginary, kind of like, oh, it's like a little prancing unicorn. No, it's like pajarito preñado. That's what I think that's the angle that they take.
So here's a question that sort of piggybacks right onto that. How do we close down the health insurance industry in New York? What's the transition going to look like? And maybe that's an unfair question at this moment, but if you can sort of address it, because I think... No, it's not, because we have thought about it, and Dick is going to tell you how we actually work. You saw how he reached for the mic and said, like, I got this. I got this because I did this, and yes, he did. Dick?
Well, a lot of people ask about, the transition. So, in December of 2022, when I went to the doctor, I handed in my insurance card. In 2023, after I retired, we went through this horrible transition. I don't know how we survived it. When I went to the doctor, I reached into my wallet and I pulled out my Medicare card. And I handed it to the receptionist, and she said, okay. And I put it back in my wallet, and that was the transition. And, there are people who lose their job and start a new job and have a new health plan. Yeah, they go through a transition because maybe the new health plan doesn't cover the doctor that they've been going to for years. But instead of handing the receptionist their old card, they hand the receptionist the new card. That's the transition.
No, that's not.
Not a problem.
No, that is not the transition.
Well, with the New York Health Act, when I go to the doctor, instead of handing them my Medicare card and my state employee retiree coverage card, I'll hand them my Medicare card and my New York Health Act
What's
card.
going on behind those cards? There's a whole infrastructure of people.
Transition,
Now, can I
Okay.
add another question? Yeah.
Yeah, New York will spend some time adopting some regulations and setting up a system for covering for handling all of those claims. It will probably bear a remarkable resemblance to the system that we've had in place for 56 years now in the Medicaid program. We know how to do that. We do it spending about 4% on administrative costs, where United Healthcare, which covers me today, spends about 5 times that on administrative costs. So yeah, the state will handle that perfectly well.
And
That's not the question.
okay, and I just want to
No.
wait. Can I?
I got this.
All right, then
There's
I'm
also, there's a transit that, we're talking about 2 different things. We're talking about the internal and the external. It is true, and this is important, that the underlying here is that as far as the patient is concerned, the transition that's gonna go out for the patient is gonna be very little. They're just gonna get a piece of plastic, right? As far as internally, and I can hear what you're saying, there is a 3-year, the bill is structured, and this is why I'm saying that they got it, because they designed it this way. There will be a 3-year period of transition. In other words, there would be a 3-year period where everything would be set up before the switch is flipped. There would be regulations created, standards created, etc., and the whole conversation would happen about how the system would function before it starts to. And then when the switch is flipped, then basically, let's say December 31st of this year, everything that happens before December 31st will be paid for and covered in the way that it was covered before then, and then everything in January 1st will be covered under the New York Health Act. Also related to insurance companies, let's say we actually figured out how many people, the Department of Labor told us how many folks work in the insurance industry. I forget the number that we're talking about. You got it, okay, so Arno's got it, you might talk about it in a second. But let's say, but it is not, first of all, it is not a large number, that's number one. Number two, we thought about this, and in the bill we did 2 things. We included language, which, we work with 1199, as you folks know, a healthcare union that has represented healthcare workers over many shifts in technology over the years. So one of the things that they have actually figured out how to do well is transition people from old jobs to new jobs, and make sure that you can train people who have a certain level of skill in the health sector, for example, and be able to have some new skills that they can actually do another job that wasn't available 10 years ago because of technology or whatever. So we would put language in the bill that relates to that training and transition. We also put money in the bill for extra money for unemployment for folks who are transitioning out of the health of the insurance companies. I'll remind you of two last things. First of all, because of the expertise of many of the folks inside the healthcare industry who do some of the administrative stuff, maybe they can come and work for the state and help us to run it as state employees. And lastly, anybody who has a job from the insurance company that loses it and is looking for a new one, while they're looking for a new one, they will have health care.
What about all those employees of doctors who are fighting with insurance companies now? Are they part of it?
Yeah, let's take questions from the.
I just wanted to briefly add that when I hear that the administrative model is going to be modeled on Medicaid, that's music to my ears as a physician, because working with Medicaid right now, especially, I think the best example would be the pharmaceutical benefits, which have been streamlined into one plan for all Medicaid beneficiaries, and it is so easy to work with this plan. I know exactly what's covered. I call them multiple times a week. The calls are quick. I get what I need, and I keep moving with my day. So this is a good thing.
Next question, Madam.
Yeah, so the same person who asked about the question you just answered about what's going to happen to all those administrators also tacked on there, what happens to all the investors who, make money on insurance?
They'll figure out somewhere else to make money, please.
AI.
Sure. They can figure out somewhere else to make money.
So-
Let's go with crypto.
There's a lot of questions physicians, and I feel like I work in a particular bubble, perhaps in the South Bronx with the folks I work with and Betty works with. But is there physician resistance to this? Do you guys know? Have you heard of that?
Love to speak about this,
Okay.
yes. Okay, so first of all, family physicians support the New York Health Act. The society that represents family physicians in New York has endorsed. Pediatricians, the organization that represents pediatricians, they have endorsed the bill. Internal medicine doctors like me and like Debbie, our national organization has a policy that we endorse universal health care via a single payer system or a public option, which we don't support that, but yes, single payer. The New York State chapter has not endorsed yet. And it's kind of a technicality where they want to survey everybody and they're not sure how to survey all the members, so that's been going on. Some of highly specialized people in, areas outside of New York City. I just went to the Medical Society meeting. There are a lot of people there who do not support the New York Health Act. And I was very disappointed. I thought they might have some arguments. I would learn about their day-to-day and their field and how they would be affected by the New York Health Act. The problem is that they are spouting the same myths and misinformation that we're hearing from people who are opposing the New York Health Act because they work for an insurance company. So what they're saying is, you're going to take away people's Medicare. Well, that doesn't make any sense. First of all, that would be, as Dick says, that would be illegal. And also, all of my arguments about this come straight from Dick. And we're improving the situation for people with Medicare. We're wrapping around their Medicare so they don't have out-of-pocket costs, so they have long-term care. So that's absolutely not true. The other interesting, weird argument I heard recently multiple times at this Medical Society meeting was, we already have a single-payer system. It's Medicaid. Medicaid pays us too low. Therefore, we're against this. So we know that is not the case right now. We're wasting, like $20 billion a year on insurance company profits. If we invested that money back into the system, then we would be able to improve payment for our providers. Also, we'd have a larger population of people who are covered. So we would all have more patients. We could get reimbursed at a higher rate. So there are a lot of reasons why this plan is really good for doctors, really good for hospitals. Right now we're seeing the threat and the actuality of hospital closures because so many hospitals are reliant on the money coming in from the federal government that's going to be cut. That would not be the case if we had the New York Health Act and we could control our own healthcare system. So there are a lot of reasons why doctors do and why doctors should support the New York Health Act, and that's what Physicians for a National Health Program is working on.
Let me add a couple of words about physicians. First of all, the question about, Medicare and Medicaid, pay doctors and other providers very poorly. That's true. They don't cover the true cost of care. And the bill declares in black and white that Medicare and Medicaid rates of payment do not meet the standards set in the New York Health Act, and that the New York Health Act will pay on top of what Medicare and Medicaid pay. That's among the gaps that the New York Health Act will fill. Now, the language in the bill that describes the criteria and the process by which the New York Health Act will set the rates of reimbursement for providers, I did not make that up. We had a meeting years ago with people from the New York County, that's Manhattan Medical Society, and they raised concern about, how would doctors get paid? And I said, what would you like it to say? And they said, well, here, they gave me a series of ideas. And I wrote it all down, and I put it into bill language, and I said, is this what you had in mind? And they said, yeah, that works. And so we put that in the bill. So the language in the bill about how healthcare providers are going to get paid was basically written by the Medical Society, who, believe me, is very focused on making sure that its members are well paid. And one more thing, years ago, the State Medical Society drafted legislation to allow healthcare providers to collectively negotiate with insurance companies. Now this isn't collective bargaining like if you all work for the same company. This is people who don't all work for the same company or have individual practices would be able to collectively negotiate with insurance companies. They needed legislation because they don't all work for the same company. That kind of collective activity would be illegal as an antitrust violation unless it is explicitly legalized by state law. So that's what that bill would do. I carried that bill for many years. When we drafted the New York Health Act, we took the Medical Society's collective negotiation bill and put that into the New York Health Act so that healthcare providers could collectively negotiate with the New York Health Act system. And we added that since, the New York Health Act system would be this, big gorilla, we put in language that said if the negotiations don't reach an agreement, there would be a neutral arbitration process set up. So we added that to the bill. Again, the language written by the Medical Society. So I think I can understand that doctors are nervous. Doctors have always been nervous. When Blue Cross was proposed in the 1930s, doctors said, oh, wait a minute, this is going to interfere with the doctor-patient relationship. This is socialized medicine. Well, it turns out it worked pretty well for them, and it made sure they got paid. So yeah, doctors tend to be nervous about these things. Hospital executives tend to be nervous about these things. But it's going to work. And, in New York, we've made it almost impossible for a hospital to collect medical debt, unpaid bills. Gustavo and I worked on that legislation. I'm glad it became law. But if I was a hospital executive, I would think, oh my God, if the patient doesn't pay their bill, what are we going to do now? Well, the answer is, under the New York Health Act, there will be no more medical debt to worry about, because they'll get paid by New York Health.
I just want to add one thing on the doctor thing. I mean, the language in the bill is, as Dick described, in our economic analysis, we of course had to put numbers on all this stuff. I would just add one thing that was not mentioned, which is that because we're getting rid of the private health insurance industry, this frees up considerable amount of time on the for the physicians and their staff. In fact, we calculated how much time that would be, and it would actually enable them to increase their billable hours by something like 15%. And we also did put numbers on how much more we would pay because we needed to put some numbers. So we pegged it at a benchmark of 110% Medicare rate, and that for all physicians. Now, again, that would be subject to local, regional, global approach that's in the bill, but that's the benchmark.
So one of our questions, which you've sort of touched on just now, but I guess I want to expand it a little bit. How much will hospitals and medical schools, how will they fare under the New York Health Act? And you talked about, well, there won't be any more medical debt, but is there resistance from these sectors and any other concerns that they might have besides that?
Hospitals in the state of New York are nonprofit by law, but many of them act as though they were for-profit companies. And those folks, the larger folks that have a lot of private payers in their payer mix, they don't like the bill. I know you're surprised. Safety net institutions, FQHCs, federally qualified health centers, you have those folks love the bill. As we stated before, the bill would have in statute that the rate to be paid, which is not determined, it's not determined in the legislation, but the board would make the determination, but the rates have to correspond to the cost of care. There's literally nowhere else where that is happening.
There's a statutory language that says that the rates to be set have to correspond to the cost of care. That means that by default, every one of these institutions, which right now, if they serve a large in-need population, uninsured or Medicaid insured, it means they're usually losing money every time somebody walks in through the door. As opposed to that, they will see their finances, they will see their revenue like stabilize. And in some instances, perhaps skyrocket, but at the very least stabilize. So it's not going to be, it's Medicaid rates are down here, Medicare rates are here, and private is over here. Well, if we set the standard right about here, you can see how the, you know, the Northwells or the Mount Sinai's or the, you know, of the world will be like, damn, could you not?
Right.
And we're like, nah, we're gonna do it. And we're gonna do it here. And this is gonna be benefiting certainly everybody. So there's certain hospitals that are saying that this is not something that's workable. They use all the same excuses that we always use. But for the most part, every single CEO of a safety net or FQHC that I've talked to in the entire state is supportive of the bill.
And then we also see that when people retire from their role as CEO of a hospital, that's when they come out in favor of the New York Health.
Here's a couple, and you might expand on other parts, things that haven't been asked, but specific questions that affect individuals. Is Social Security covered as part of income, and how to address, and I'll leave that to later. Does the New York Health Act cover me when I'm out of state? I think people have specific concurrence. Those are two.
The definition of income that would be subject to the New York Health Act is basically, it's got to be something that is currently taxable under the New York State income tax law. So that's the first criterion that would apply. Now there are then two pieces of the New York Health Act tax. There's the tax on what is called payroll, earned income, which would be any income that is today subject to the Social Security tax, and then it would also apply to income that is separate part of the tax, would apply to income that is not considered payroll income, but still it would have to be income that is subject to the New York State income tax. Does that answer the question?
Do you want to talk about the first 25,000?
Oh, yeah, and the first 25,000 of your income would be at a zero rate. In other words, it would be exempt from the tax. If you're a Medicare enrollee, the first 50,000 of your income would be exempt from the tax. As I said earlier, in recognition of the fact that as a Medicare enrollee, you are drawing in a big chunk of federal money into the New York healthcare system already.
Out of state.
Okay, and then
I'm out of state, yes.
Oh, out of state. If you're a New York resident and you are temporarily out of state, the New York Health Act will pay the bill. And I usually use 3 examples. You're hiking in the Grand Canyon and break your ankle. The New York Health Act will pay the hospital in Colorado where you go to get your ankle fixed. If you're a New York resident and you're living in Florida for a couple of months of the year, and you go to the doctor, the New York Health Act will pay the bill because you're a New York resident. If you live, for example, in Eastern Connecticut, Eastern Dutchess County, and your doctor is down the road in Connecticut, and I always use that example because my parents used to have a house in Eastern Dutchess County, the New York Health Act would pay the bill when you go across the border to Connecticut to see the doctor, or if you go to the Sharon, Connecticut hospital, to get your care. So that's all spelled out in the bill.
okay. I think we're over time. I was just informed. So sorry.
Let's go again.
Yeah, I think think we can take one more question. I don't know if, like, yeah, this poor person's had her hand up for quite a while, and then we're gonna.
Is there a state that has something like New York Health?
We can't hear.
The
Other
question,
states. And one person asked specifically about Vermont, and then
Yes.
it did not go well, yeah.
So, okay, so there is no state currently that has a system like this. The state that's gotten the most is Vermont. Vermont passed a bill, and the problem was that it was not as well cooked as ours is, meaning it didn't have a funding mechanism. And so the governor pulled the plug before the switch was flipped. So, and funny enough, I actually had a great conversation. So the new, I don't know if you know this, but the new Commissioner of Health for the City of New York, Dr. Alistair, I forget his last name.
Martin.
Dr. Alistair Martin. I just got to know him recently, and I'm really liking to do a lot of stuff he's doing. But then the other day, I had a great conversation with him. And one of the things that he told me is that he was actually on the staff of the Vermont governor when that was happening. So I'm going to have a whole download with him because he has a lot of ideas about both some of the technical aspects behind the scenes, as well as the political difficulties that they had, as well as the communication issues that they've had. So I'm really looking forward to picking his brain about that. But then California passed the bill out of the the California State Senate years ago. It died in the Assembly, but that one also was because they hadn't thought through the funding mechanism. In that case, the way that it works in California is just bananas. I think you know this, obviously you know this because you know about a bunch of state legislatures. It threw me for a loop. The way that it works in the Senate, in the legislature here in New York, is that if I have a bill, there has to be the same as in the Assembly, right? So it has to be word for word the same bill for it to pass. California doesn't work like that. You can have a bill of mine that is linked to yours, but they're not the same. They're kind of about the same thing, but they're not the same. And then I can pass mine, and then you have to pass one. There's a whole other process that's involved. So in that case, what happened, and I've talked to some friends of mine who were legislators who were there at the time, they saw it as a political necessity for them, and they just threw it in the lap of the governor in the Assembly. And then they walked away, they were like, oh, you do it now, we did it, now you gotta do it. And ultimately it led to it not getting signed. And as far as Massachusetts, what happened in Massachusetts was an earlier version of what ultimately became Obamacare, right? And that's just certainly a slightly better thing because it creates a marketplace, but it's a marketplace of private insurance plans. So it was an earlier version of what ultimately became Obamacare, so they did not have. So there's no state that has done this. I should tell you, this is another thing that I forgot to mention earlier. There is a coalition. Right now there's something like, there's like 35, 36 of us, of legislators from across the country who are sharing either introducing bills there, introducing study bills, and actively talking about this in their states. And we're collectively working and organizing to actually raise the temperature on this across the country. And as it's often, and it's something I say, that legislating is the only place where plagiarism should be encouraged. Like, I got no problem if you want to steal my bill and pass it in your version of yours. So there's also that momentum that is being built there. So, and there's a friendly competition amongst many of us to see who can actually get one passed.
Yeah, my apologies as the moderator at the end. I went over. I apologize. There are a lot of questions that did not get asked and answered. So please, you have information on how to contact these wonderful people. Contact them and ask them your questions. Thank you very much.
Thank you. Thank you to the speakers. Thank you to the audience. Please stop by the table before you leave if you have time.
Great. Thanks, everybody. Thank you, Dean Weatherall, for filming today. So this is going to be available.
Yes.
Our next general meeting is May 17th. Check out our newsletter tomorrow.